So, greetings from Gujarat. Uh, I'm going to speak on medical management of male infertility. As you know, male infertility affects 9% of the male population, and 50% of the couples coming to our OPD for infertility have a male factor. There is a marked regional variation in different states of India, and particularly in Western India, Gujarat, we have as high as 65 to 70% male factor. In our clinic, we see almost 5 to 7 patients daily of male and even 2 to 3 patients of azoospermia. This is probably due to an increased tobacco consumption. We have a large consumption of gutka in our area. 1% of all males suffer from azoospermia, and 3 out of 10 male patients coming for infertility have azoospermia in our center. Now, evaluation of male factor is centered around a patient's seminogram. We usually see the patient take his history, but we also ask him to come get a semen report done. A good standardized semen analysis report, at least 3 reports, and we review all the previous reports and make a chart of that. With an abstinence period of at least 2 days is the most basic investigation. Semen analysis has a sensitivity of nearly 90%, and we rely on it as a marker for male infertility. Serum FSH, serum testosterone, and DNA fragmentation tests also provide information regarding testicular function and sperm DNA damage. As you know now that the 5th percentile values are the minimum values required for fertility: 1.5 ml volume, 7.2 pH, 12 to 16% concentration, a motility of at least 31% progressive, and a morphology of at least 4%, a 58% vitality, and a WBC of less than 1 now, 1 in 10 squares of the macular chamber, and 50% of antibodies. Total motile count we always do in all the cases, and it is usually written on the lower left hand side of the semen report, and it's the count multiplied by volume multiplied by motility. Now, oligoasthenoteratozoospermia, as you know, is a category of subfertile males where all the 3 parameters of sperm function are affected, namely concentration, motility, and morphology. And generally, most of our patients who come to the OPD have 1 or more parameters altered, and they would fall into the category of OATS, mild, moderate, or severe. The common causes of OATS are varicocele and genital tract infections, which we try to rule out first. In evaluation of the infertile male, we ask for history of undescended testes, history of tobacco, alcohol, drugs, exposure to venereal disease, history suggestive of filariasis, trauma, heat exposure, any operations done particularly in childhood, mumps, typhoid, orchitis, problems of intercourse, consummation of marriage, erection, orgasm, masturbation, frequency of intercourse. So a detailed history and as well as sexual history is taken, and history of all the risk factors is included. In examination, we do a general examination for endocrinopathy. We look at the general height, weight, the obesity, and also gynecomastia, axillary hair, pubic hair, etc. And we look for the testicular size and the position. We look for a turgid epididymis, particularly in obstructive azoospermia. We examine the vas and epididymis, and a rectal examination is also done for seminal vesicles and prostate. Scrotal skin, penis, phimosis, hypospadias, epispadias, etc. is looked for, and hernia, hydrocele, and varicocele is ruled out. I already told you this: masculinization, sex, secondary sex characters. Testicular volume, usually 18 to 24%. We use an orchidometer or simply a foot ruler, a simple plastic ruler. The vertical length of the vertical axis of the testes, if it's more than 4.3 centimeters, it is normal. The epididymis is either flat or turgid, and presence or absence of vas deferens. This is the Prader orchidometer. We have another one. I think Ames orchidometer is the one that we use. And in the investigations, at least 3 reports of semen with an abstinence of 2 to 3 days, count, motility, morphology according to the strict Kruger's criteria, viscosity, liquefaction, and we centrifuge and examine the pellet in case of azoospermia. Investigations, we do routine blood counts. We always do sugar and creatinine. We are able to detect a lot of borderline kidney decompensations as well as diabetics. The blood group VDR, HIV, HB, SAG, and FSH and testosterone we do in all cases of male infertility, even if one semen parameter is altered. And in cases of severe oligospermia and azoospermia, we also do LH, prolactin, and estradiol. Anti-sperm antibody tests are done like IBT-MAR and testicular biopsy is not done routinely, but in cases of azoospermia, we have now started doing needle biopsies of the testes, a live needle biopsy to also see the sperms, retrieve the sperms, and then send the tissue for histopathological examination. American Urology Association recommends serum FSH testosterone in all cases of initial hormone assessment with prolactin, estradiol, and LH in severe oligospermia and azoospermia. An elevated FSH level greater than twice the normal limit is a reliable indicator of abnormal spermatogenesis and severe testicular dysfunction. However, focal areas of spermatogenesis may be present in patients with highly elevated FSH, and that is the basis of a micro-TSA. Recently, a stronger correlation has been demonstrated between inhibin B and spermatogenesis. Now, what is the rationale of treating male factor? The rationale is that in borderline sperm counts, aim is to try and improve semen parameters and achieve a pregnancy by natural methods or IUI and thus avoid an inevitable ART outcome. Specific treatment is indicated when the specific cause is known and it is outlined. Non-obstructive azoospermia requires specific pre-treatment to improve chances of sperm retrieval. We now have nearly 75 cases of such cases which we have put on treatment. Empirical treatment is given in all other cases of male subfertility with altered semen parameters to improve the reproductive outcome. Now let us go on to the specific therapy. First is hypogonadotropic hypogonadism. Low FSH, low LH, low testosterone. Usually the testicular volume is small, 20 to 30%. There may be azoospermia or a severe oligospermia. Many of them have sperms in the ejaculate. And here the treatment is actually of two types. One is for steroidogenesis and the other is for spermatogenesis. I'm going to tell you the treatment that we give for spermatogenesis. We give gonadotropin therapy with HCG 2000 units 3 times a week for 6 months. And at the end of 3 months, we supplement it with REC FSH 150 units 3 times a week for the later 3 months. And this is good enough to induce spermatogenesis in many patients. In large percentage of cases, more than 50% of the cases do get sperms with this treatment. Borges et al. Has reported 80% of azoospermic men to have sperm in their ejaculate in a median time of 5 months. Of course, in many patients cannot afford REC FSH 150 units. In these cases, we give urinary FSH for 3 months. Therapy should be started 6 months prior to planned fatherhood. If they don't have sperms in hypo, we give treatment for 6 months before we attempt a sperm retrieval. Lot of evidence available. Gonadotropic treatment starts with administration of HCG. As we all know that HCG is required for spermatogenesis. You have to prime the testes, the germinal follicles with HCG. Whereas HMG or REC FSH added later on is responsible for spermiogenesis, that is the maturation of the sperms. But HCG is a must, so treatment is always started with HCG and then later on HMG or REC FSH or urinary HMG is added. The two important things here is the rigid discipline is needed because both compliance and cost, these are important. So in my patients, I usually get it directly from the company and I am able to give them HCG at a very low rate and also give them HMG at a very low rate. So they are able to complete the entire treatment of 6 months within 40 to 50,000 rupees. Now, leukocytospermia, the second specific cause where the cause is known. This is presence of pus in the semen or pus cells in the semen. This is characterized by pus cells 1 into 10 raised to 6. Neutrophil granulocytes need to be differentiated from round cells and immature sperm cells, and hence a stained smear is always done. The WHO cutoff is 1 into 10 raised to 6, and recently a lower cutoff has been suggested that even 0.1, that is 1 leukocyte in 100 squares of the macular chamber, is enough to qualify for leukocytospermia, enough to give reactive oxidant species to cause sperm DNA problems. Usually it is due to prostatitis and seminal vesiculitis, that is the accessory gland infection. Semen cultures we usually do because patients have now started asking, are you doing cultures and antibiotic sensitivity? Leukocytospermia causes production of reactive oxidant species and free radicals which cause sperm DNA fragmentation and reduce sperm motility. The common organisms are E. coli, urea plasma, chlamydia, klebsiella, and pseudomonas. And the antibiotics used are doxycycline, quinolone, micacin, and azithromycin. My personal preference, I always start with doxycycline and then usually give plurifloxacillin because I read 2-3 reports of plurifloxacillin among the quinolones giving very good results. And azithromycin, of course, is nowadays favored. Two important things. One is according to body weight, you have to increase the dose. If the patient is 100, 120 kgs, maybe double the dose. And 150 kgs, we have many patients with 150, 160 kgs. So they need a much higher dose. And the duration should be at least 14 to 21 days. And in resistant cases, I give Micacin injections, 500 milligrams twice daily for 10 to 15 days. 15 days, usually 2 weeks. And in addition, in very resistant cases, I give intraurethral injection of diluted Micacin in 10 ml of distilled water by a simple needle, simple syringe, which is attached to the uh, um, meatus, and you carefully push the distilled water with Micacin inside. Results of treatment are satisfactory and usually result in increased sperm counts. Antibiotic therapy is usually combined with antioxidant treatment. Of course, in many of these patients, DNA fragmentation tests have been done, and we can use that as a marker or as a prognostic indicator. In the literature, of course, most of the antibiotics give 70 to 80% success rates and uniformly good success rates. So I think cost again is important here. Hyperprolactinemia, we are seeing quite routinely, and the treatment is, of course, cabergoline. Nobody uses bromocriptine anymore, but cabergoline 1 milligram per week. I give 5.5 milligram twice weekly for 1 month. It is very strong. It causes drastic reduction in prolactin levels. And sometimes in 15 days, the prolactin levels come back to normal. If the prolactin levels are more than 100, we look for a microadenoma. And if it's more than 250, we also look for a macroadenoma. Immunological infertility as detected by, confirmed by antibodies, IgG, IgM antibodies detected by MAR test. And we give prednisolone in tapering dose. I'm a little scared to give 160 milligrams of prednisolone. I give isolone 20 or 40 milligrams depending on the body weight, 4 times a day, 3 times a day, twice a day, and once a day, tapering over a 2 to 3 month period. In erectile ejaculatory dysfunction, that this is the last specific cause of infertility. The commonest thing that we encounter is inability to give the sample, and we give in situational and ejaculation, they are unable to give the sample. This can be prevented by simple methods like a comfortable room, putting a don't disturb sign on the room, accompaniment of the partner, sometimes getting the sample from home if they are able to get it in time. Masturbation with visual stimulation, you can use vibrators sometimes, coitus interrupters with silastic condoms, and use of stimulants like Viagra. I usually give Zydalis Express. Now you have not Zydalis, which is the Tinagra Express. It's a sublingual mouth dissolving tablet of sildenafil. But these patients who are unable to give, I usually ask them to take 10 milligrams of tadalafil on the previous night, and in the morning I give them sublingual or some mouth dissolving sildenafil. This is the kind of vibrator that we use. Electroejaculation, I don't have this instrument. We have not done it here in our hospital. Now we come to non-obstructive azoospermia. Patients with azoospermia who have testicular failure or hypergonadotropic hypogonadism. Classically, these patients have a raised FSH. The testosterone may be normal or may be low. However, it is believed that there is an imbalance between the circulating testosterone and the estrogen levels, with the lower intratesticular levels of testosterone with a T to E ratio of less than 10. Now, in many cases, we are able to get T to E ratios less than 10. But simply doing testosterone also gives us an idea. If the total testosterone levels are less than 250, 300 actually is the cutoff, but if it's less than 250, I give them HCG injections, 2000 international units, 3 times a day. I have now 75 patients, who on such therapies in non-obstructive azoospermia prior to retrieval. Initially, we used to do the retrieval because the gynecologists used to almost give me hardly any time to treat the male. Now we give this treatment and we do a needle biopsy as well, because we give aromatase inhibitors in these patients, because aromatase inhibitors, as usual, as you know, prevents the conversion of testosterone to estradiol and therefore increases the intratesticular levels of testosterone. And 2 to 3 months, Adova or letrozole. These are the two preferred aromatase inhibitors. I usually give Adova and sometimes letrozole. As you know, the cholesterol pathway, pregnenolone, progesterone, 17-dehydroprogesterone, androstenedione, and then testosterone. And then, as you know, a lot of it gets free testosterone and bound testosterone to albumin globulin, and much of it gets converted to DHT. by the enzyme 5-alpha reductase, and the other testosterone goes into the aromatase pathway to get converted to estradiol. A lot of evidence in literature all started, I remember, I think it was Amsterdam, Cornell. They had a huge session for this aromatase inhibitors and gonadotropins in non-obstructive azoospermia. It was in 2009, I think, in Amsterdam. And it was very interesting at that time. And we started giving these treatments at that time. A lot of evidence in literature. Anastrozole, Raman and Shelgel evaluated effects of anastrozole, and all treatment groups had a statistically significant increase in T2E ratios and improved semen parameters. Letrozole, many studies by Cavallini et al. And Salem et al. Definitely showed increase in testosterone levels, and also some of them did have sperms in the ejaculate as well. You need to give it for some time. Gorgio et al. Treated some 29 men with low T2E ratios for a period of 6 months with letrozole 2.5 milligrams, and with very similar increases in total testosterone and decrease in serum estradiol was observed. Increases in sperm concentration and morphologically normal sperms in the ejaculate were also seen in patients treated with letrozole and anastrozole. There are, as you know, the aromatase inhibitors can be steroidal and non-steroidal. And steroidal we are not using; it's not available here in our area. Testolactone 50 to 100 milligrams per day, and anastrozole, tamoxifen, and letrozole, of which anastrozole and letrozole are popular. Best results were reported with anastrozole 1 to 2 milligrams in combination with HCG for a period of 4 to 6 months, as compared with testolactone with HCG, which had 54% results. Now, gonadotropins in NOA. In non-obstructive azoospermia, people with the negative TESI sometimes insist on giving their own sperms. They say, please try again, please try again. Of course, we try to cause as minimum damage to the testes while doing the TSA. And if they want a repeat testes, we usually put them on this treatment. This treatment has been recommended by Shiraishi et al. The rationale of this treatment is high levels of exogenous gonadotropins suppress or reduce endogenous gonadotropin secretion, which results in resetting of the FSH and LH receptors in the Leydig cells. Shiraishi et al. Gave 5,000 international units of HCG 3 times a week to 28 patients of non-obstructive azoospermia with negative TESI. And if the FSH declined after 3 months, he gave rec FSH 150 international units 3 times a week for the next 2 months. This resulted in a second successful TESI in 6 patients. A lot depends on the histopathology. In most of the things, even in varicoceles, even in gonadotropins, even in aromatase inhibitors, if the testicular biopsy shows hypospermatogenesis or late maturation arrest, then the chances of the sperms coming are good. If it shows Sertoli cell only syndrome or early maturation arrest, the chances of all these things acting are very less. Now let us go. These are the specific conditions where we give treatment for in male infertility. Now let us go on to empirical medical management of male infertility. Now we all know we give anti-estrogens. Many people give clomiphene citrate and letrozole to patients with empirical subfertility, with low counts and low motility. What is the rationale? The rationale is anti-estrogens. So they reduce the circulating estrogens, and thereby by negative feedback stimulates FSH and LH. FSH causes spermatogenesis, but the LH stimulation sometimes precedes the FSH stimulation, resulting in spikes of testosterone levels, which in turn suppress FSH or suppress spermatogenesis. So this is important to know. So not everybody gets good results. There is level 1 evidence only. There is no evidence-based medicine does not tell us that you should use these drugs. Limited results have been reported. There are a lot of publications of anti-estrogens as well as gonadotropins. Now, which patients will you give anti-estrogens? Patients with low counts, low motility, with low FSH and low testosterone. These are candidates where you can give clomiphene citrate, and you can give it for about 3 months. And you can try and see, but you should monitor testosterone levels as well as sperm levels as well, because if it's giving negative results, you should stop the clomiphene citrate. Same with gonadotropins. Empirically, in patients with subfertility with low counts, can you give HCG and HMG? You can give, but again, evidence does not indicate the benefit of these. There's very little evidence to show that HCG and HMG injections benefit these patients for empirical management. Again, here the same principle and monitoring of testosterone levels is important. Testosterone is not used, we do not give testosterone directly because it can lower FSH and LH and thus inhibit spermatogenesis by negative feedback. And Jacquard, very early in 2003, in her book, has written that 6 to 10 injections of testosterone given daily can render an anormospermic male azoospermic. Now, antioxidant therapy, favorite of everybody. Everybody gives antioxidants. Why are they given? To counter the reactive oxidant species. Now, what are these reactive oxidant species? Reactive oxidant species are free radicals of chemical intermediates that have one or more unpaired electrons. Now, in the course of energy production in the sperm mitochondria, free radicals like minus OH, minus O2, etc. are formed, and these are normally scavenged by dismutases, by glutathiones, by normally in the body, tocopherols, etc. Excess of ROS leads to cellular dysfunction. Now, what does this cellular dysfunction do? It usually first affects the cell membrane and causes toxic lipid peroxidation of the cell membrane. It then goes on to the mitochondria and affects the mitochondrial DNA, RNA, and reduces energy production. And later on, it causes DNA damage, the nuclear DNA. And this DNA damage may be in the form of single or double strand breaks, nucleotide modifications, base loss, aberrations in chromatin packing, and telomere shortening. Most of these things, drugs, smoking, fever, cancers, systemic infections, act through the mechanism of reactive oxidant species. Most of the problems that affect the sperms or spermatogenesis act through reactive oxidant species. Of course, leaving the genetics apart, genetic causes apart, through reactive oxidant species or through increase in inhibin B, that is endocrine dysfunction. All these chemicals which we are exposed to, they are also responsible. Personal care products, plastics, the industry solvents, the contamination of water, endocrine disrupting chemicals, pesticides that we use in plants, all of these plastic products, bisphenol A, bisphenol S, these are chemicals which are used to harden or soften the plastic. That is why the plastics are now being shunned, and they are also responsible for infertility to some extent. Now, how do you manage ROS related infertility? Basic management of ROS related infertility is lifestyle modification. You have to control the obesity, reduce the weight, reduce alcohol, prevent smoking, do not consume tobacco, have a good diet, reduce stress, have good sleep, avoid activities hitting the scrotum, use proper ventilation, use personal protective equipment if you are staying in highly polluted areas. Like, for example, even in Vapi or in Ankleshwar in Gujarat, we have very high levels of chemical fumes particularly in the night, smog. And so we have to really care. You might even have to relocate for that matter. And of course, treat the infections, that is leukocytospermia and varicocele. So if you do all this, and in addition, you can give vitamins, food supplements, and antioxidants. So all these together constitutes the management of ROS related infertility. Now, antioxidants like vitamin A, D, C, E, alpha tocopherol, biotin, thyroxine, levocarnitine, coenzyme Q10. Now, in abroad, I have seen they are using plain vitamin E, they are using vitamin C, they are using this. But nowadays, I attended a lot of lectures by our own Ashok Agarwal as well as Mohammad Reza. These are the two people who gave us a lot of evidence regarding levocarnitine, acetyl levocarnitine, and coenzyme Q10. Now, combination of these drugs are available in India. We have lots of combinations in the form of powders as well as in the form of they reduce oxidative stress, scavenge free radicals, and reduce DNA damage. They stimulate mitochondria and increase energy production and stabilize the cell membrane. Different preparations, as many as 120 preparations we counted available in the Indian market. What is important is the dose and the combinations, what dose of each. Coenzyme Q10, at least 200 to 300 milligrams, levocarnitine, 1 to 1.5 grams, astaxanthin, 8 milligrams, zinc, 30 milligrams, lycopene, 5,000 to 8,000 micrograms, folic acid, 1,000, B12, 1.5 micrograms, selenium, 1,000 micrograms, 100 micrograms, L-arginine 3 to 5 grams, and citric acid 100 milligrams. I personally give one 300 milligram CoQ, and in addition I give a sachet which contains all the remaining ingredients. So more or less this is covered. Empirical antioxidant therapy may be given for up to 2 to 3 months as the spermatogenesis cycle is of 63 days. Usually 45 days is spermatogenesis and the spermiogenesis is the other 18 days. There is now emerging evidence on the benefit of CoQ 300 and carnitine and acetyl levocarnitine in increasing sperm motility. Lot of evidence available, Bingham et al., Agarwal et al., Buran et al. Is showing improved results with improved IUI results with and even natural pregnancies with DFI and improvement in DFI values. Bangam et al., Zini et al. A large study of 2,549 ICSI cycles and meta-analysis 2011 and 2016 evaluation of all these reports showed that oral antioxidant supplement used in male infertility can help to increase the pregnancy rates. So to conclude, my dear friends, specific medical management when indicated should be instituted. When specific cause is not known, what you give treatment is called empirical medical therapy. And in many of us are called upon to give some treatment to people to improve their counts. This is known as empirical medical treatment, which I have outlined. There is emerging evidence on the role of antioxidants in ROS-induced OATS, and this may be given for 2 to 3 months. There is a specific indication for medical management in non-obstructive azoospermia. Again, level 2 they say, but evidence. But we are doing a study, our own study. We have now results, encouraging results are coming, and medical management should be given along with IUI and ART options. Thank you very much.